somewhere beyond traditional thinking, beyond standard treatments, is a place that bridges where we've been to where we're driven to be. It's where innovation that saves and sustains lives meets the providers who make it happen. Where our ability to manage illness expands to reach patients with limited options. Where we address complications before they become life-threatening. Where we're not only treating diseases, but also discovering smarter ways to prevent them. This is our place, where we come together to write our greatest chapter as a visionary company operating at the center of global healthcare. This is the intersection of our boldest possibilities. This is the new Baxter.
Good afternoon, everyone. I would like to extend a warm welcome to you this afternoon in the Allied Breakaway session. Our first speaker of the afternoon is Irene Angelo, who completed her BSc in Physio in 2011 and went on to do her Masters in 2020, both from WITS. She's worked in the UK for a year, where she gained valuable work experience, which led her to do her Masters in Burns. Her MSc dissertation is what she's going to share with us now. Welcome, Irene.
Thank you very much, Moira. So my studies on the clinical outcome of Burns patients in South Africa in a private setting. I hope you enjoy. Good day, and thank you for the opportunity to present to you a retrospective study regarding the clinical review and functional outcomes of patients with major burn injuries in the private sector. Globally, burn injuries cause approximately 180,000 deaths per year and are the leading cause of morbidity in cases that are not fatal. In middle to low income countries, one of the main causes of disability-adjusted life years lost are burn injuries, specifically burns caused by fire. It has been seen that approximately 1 million people in Africa sustain burn injuries every year. This article is aimed to describe the demographics, burn characteristics, clinical course, physical function, and complications developed after major burns, as well as to establish predictors of non-independent physical function at hospital discharge. The records of all the adult burn admissions to a level 1 trauma center between 2015 and 2017 were screened retrospectively against our criteria by the research trauma nurse using the Trauma Bank data registry. The same records were also obtained from the physiotherapy practice that services the burns ICU. The anonymized data from the included records were captured on a specifically designed data extraction sheet. Time points for the data collection were patient admission to the burns ICU, patient transfer to the general ward, and at discharge from the hospital. The verification of the data capturing process was performed by one of the authors on a portion of the data to ensure accuracy of data capturing. Results. A total of 303 patients were admitted to the Level 1 Trauma Center between January 2015 and December 2017. Of those, 219 were excluded due to minor burns or death. The remaining 84 were screened for the study. The study inclusion criteria included patients with burns of 20% total body surface area or more, excluding superficial burns with or without an inhalation injury. The exclusion criteria included patients with complex lower limb injuries, for example, those who had an amputation because of the extent of the burn injury, or those who had complex fractures to the pelvis, femur, tibia, and fibula, which delayed mobilization. Other exclusion criteria included spinal cord injury and cognitive disorders, for example, dementia and traumatic brain injury, this leaving the final number of records included in this review at 73. As you can see in this table, the age of the patients ranged from 19 to 88 years of age. The majority of the patients were male and of Black ethnicity. The injury severity score ranged from 1 to 32. The Borg score and the revised Borg score presented as a mean of 78.5 and 93 respectively. The gender ratio in our cohort favored males, which contrasts with an existing South African study that reported a 1-to-1 ratio for adult males and females who were admitted to a tertiary hospital in KwaZulu-Natal. Age ranges compared well with those reported for adults in the KwaZulu-Natal cohort. It has been reported that an injury severity score of more than 15 is associated with a 10% increased risk of mortality. Similarly, a revised Borg score of more than 75 is associated with a 50% mortality risk. This led to the conclusion that the risk of mortality was therefore increased in our cohort. Thermal burns were the most common type of burn sustained, and injury to the arms and head were most recorded. The total body surface area burned showed a minimum of 20% and a maximum of 77%, with 17 of the patients recorded having inhalation injury. The high incidence of thermal burns observed is similar to that reported for adult patients in the KwaZulu-Natal cohort. However, a higher incidence of inhalation injury was observed compared with the 14.3% reported in the KwaZulu-Natal study. The median percentage of total body surface area injured is higher than that reported for adults in the KwaZulu-Natal cohort, who had a shorter hospital length of stay of 22 days. From the table seen here, of the 73 patients, 33 were sedated and 32 were intubated and received mechanical ventilation. 3 of these patients were recorded as needing to be reintubated. The maximum ICU length of stay was 81 days, with the hospital length of stay reaching a maximum of 243 days. In this cohort, the maximum number of theatre visits was 29, and as many as 21 complications occurred. 2 of the most performed surgical procedures for this patient cohort were wound debridement and skin grafts. The most common complication reported in the physiotherapy records for this cohort was edema formation. Other reported complications included pyrexia, low hemoglobin, diarrhea, blisters, and infection. Our review included only patients with major burns, which could explain the high rate of wound debridement surgery performed and the longer hospital length of stay. Edema formation is a known tissue response to burn injury and surgical intervention and is therefore an expected finding. The areas that were most affected by burn injury were the head, upper and lower limbs. Not many studies report on the location of a burn, but it has been observed that the burning of victims' clothing principally affects the lower limbs. This table shows the progression of range of motion from ICU discharge to hospital discharge. Small or no improvements in joint range of motion were recorded for the affected areas at patients' transfer from ICU to the general ward and prior to hospital discharge, despite physiotherapy management being given to all patients during hospitalization. Early physiotherapy rehabilitation of patients admitted with burn injury to prevent complications associated with active joint range of motion is supported by other studies. It is possible that lack of patient compliance with physiotherapy management or the repeated need for joint immobilization after multiple surgeries contributed to the decreased range of motion recorded at these time points. Most patients presented with fair muscle strength, as indicated in their physiotherapy records, at the time of transfer from ICU to the general ward and prior to discharge. 2 patients had bilateral shortened Achilles tendons, and 2 patients had bilateral reduced axillary spacing at hospital discharge. The median functional status score for ICU at transfer from ICU and prior to hospital discharge were 35 and 35 respectively. Prior to hospital discharge, 39 patients were recorded to be independently mobile and 21 were independent with stair climbing. It is reasonable to conclude that the patients responded clinically to the rehabilitation received for regaining their muscle strength. A study observed that a structured exercise program, specifically isokinetic training, improves eccentric and concentric muscle strength in patients with burn injuries. In the United Kingdom, patients presented with low levels of physical function on admission to burns ICU. Their functional abilities improved as they were discharged from ICU and further improved prior to hospital discharge. Adults recovering from burn injury present with decreased peripheral muscle strength and limitations in exercise endurance at hospital discharge when compared with age and gender-matched healthy subjects. None of the variables identified were predictors of non-independent function at hospital discharge, as the p-values were not significant. In this instance, the functional status score for the ICU was the outcome measure used. In this record review, it was noted that adults admitted with major burns to a private trauma center are predominantly male, in midlife, and sustained thermal injury. They have a high injury severity with a prolonged hospital stay. Independent function was recorded for most patients at hospital discharge. These findings contribute to the limited body of evidence on the profile, clinical course, and outcomes of South African adult burn patients. As this is one of the first studies of its kind, it highlights many areas that need to be researched. It should be noted that future studies should possibly focus on each objective noted in the study as a separate entity in order to gain more in-depth knowledge of the physical functioning of patients with major burn injuries and what affects their physical functions. Perhaps these discrete studies should be conducted prospectively in order to describe changes in physical function more accurately. Future studies could be conducted with a larger sample size. If another study of this nature were to be conducted, it is recommended that the milestones achieved should be stipulated at more regular intervals and in a reduced time frame, thus allowing more information to be processed in order to obtain a more conclusive analysis of the data. For those of you interested in reading the full review, it can be found in the South African Journal of Physiotherapy, as it will be published by the end of 2021. Thank you for your attention.
Thank you, Irene, for that interesting presentation. I want to ask you, could there be another reason for the shortened tendo Achilles in 2 of those patients? Have you any idea why 2 of those patients would have shortened TAs?
Yes, it might be the tightening of the fascia, which is there, so it's pulling on the Achilles tendon and thereby shortening it. In saying that, though, we would actually need to do a study that actually focuses on that to actually get a more conclusive answer.
Because all patients are wearing resting foot splints, like from day one, to try and maintain the integrity and the stretch of the TA. So I'm just wondering why 2 of them seem to have shortened TAs. And can I also ask you about why the FSS ICU score median was both 35 when they were discharged from ICU and from the ward? Why are those scores the same?
Yeah, so the scores were the same. I think it was because it was a small sample size, even though these were the patients that could be included in the study. I do think what is important to note, though, is that the minimum score in the FSS ICU at ICU discharge was 12, and that increased quite markedly to a 22 at hospital discharge, and that's out of 35. So I think that would be the more take-home points, let's say.
Yeah. Thank you, Irene. Thank you for presenting.
Thank you very much.
My pleasure. The next speaker that we have up is Chantel Mostert. Chantel is a dietitian who studied dietetics in Stellenbosch and started working at Netcare Mill Park in 2007. She started a private practice there in 2012, and her special interests include trauma, burns, critical illness, and transplantations. She's delivered many presentations at many local workshops and conferences and has won 2 awards in an international nutrition survey, Best of the Best. Welcome, Chantel.
Thank you. I'm just sharing my screen. Okay, can you guys see that?
Chantal, we can't see your screen just yet, sorry. Please try again there. You'll need to share, click on share and share full screen, please.
Great, I think
there we go, it is coming up. Please go into full screen.
There we go.
Fantastic,
is that fine?
Thank you.
All right. Thank you for the introduction, Moira. I'm going to talk to you a little bit about the nutrition therapy that we use for burns patients. And when we look at critical ill patients, we usually see that there's an inflammatory response. But when it comes to burns patients, you can imagine that this is like a tsunami. The inflammatory response is huge. This is a very interesting study that was done just after the Second World War, where researchers wanted to have a look. What is the metabolic changes that happens in the body when a patient is starved? And as you can see with these 2 men, they were starved for approximately 3 months on a restricted calorie diet, but they still have muscle mass. They've lost quite a lot of their fat mass. This is an anesthetist. He works at Duke University Hospital. You can see in 2014, pre-illness, he was quite well built and he had quite a lot of muscle mass. And a month later, after his ICU stay, the muscle wasting was there. And why does this happen? Because when we look at our resting metabolic rate, in critical illness, it increases, but during starvation, actually, your resting metabolic rate will go down. And especially if you look at the major burns patients, just look at that extreme metabolic rate. And the same happens with nitrogen. So nitrogen is basically the derivative of protein. During starvation, our body preserves our nitrogen and our lean body mass. But during critical illness, we lose quite a lot of protein and nitrogen. And we can see this in our burns patients. And you can also imagine this is a 1 kilogram steak, and this is what you lose. You can lose in a hypermetabolic patient during critical illness. And it's important to always keep this little picture in your mind when you are feeding patients in the ICU. This resting metabolic rate actually continues not just during the admission, but actually even 12 months after the injury, patients still have an elevated resting metabolic rate. So it's important, the post-discharge education that we're doing with patients as well. So it starts off high and then it does taper off, but it still remains high. So what is the correct approach? And it's never just one thing. Remember that nutrition, we want to make sure that we're providing nutrition, but at the same time, it's important that the inflammation is kept under control. And this is usually done by early closure of the wounds, early debridement, making sure that the appropriate antibiotics are prescribed when there is infection. And also from our physiotherapists and occupational therapist side, that we want patients as mobile as possible, because all of this, the 3 things work together to reduce muscle atrophy and as well as muscular weakness. And then our outcomes that we're looking for is that we have a shorter length of stay in hospital, but also a patient that has a better functional quality of life and a shorter time on the ventilator. So what do we do? Where do we start off with what we need to do in the burns unit? Who's important? So I'm going to go through a few things. Who do we need to feed? When do we feed them? What are the nutrients and what is the route that we're going to use? So starting off with who, any patient that gets admitted with more than 20% total body surface area will require additional nutrition support. They require monitoring, and therefore they would need to be referred to a dietitian. Some of the other things that we also need to take into consideration is age. For example, if an elderly patient comes in with only 2 or 3% burns, they might still require additional nutrition support. Any comorbidities, their nutritional status before they get admitted, and then also any additional therapy like the ventilation, CVVH can influence the patient's nutritional requirements. Because what is the problem if you're not feeding them well? You have problems with wound healing, 4 times higher risk of pressure ulcers, longer time in ICU, difficulty getting off the ventilator and mobilizing, and then also a very high risk of infections. And this can all then add up to the cost that is accumulating. So yes, we have a problem, and we need to make sure that we are feeding our patients, because when you look at a 3 times higher hospital cost, that is a very important thing to keep in mind for both in our private and our public sector, but also the longer length of stay, because we need those beds. There's so many patients that suffer from burn injury, and often, like today, we actually have a full unit, and a available bed could mean that we could help a potential another patient. When do we want to feed them? And there's something that we need to keep in mind when we're looking at the Hippocratic Oath, that we first must not do harm. So we're all very enthusiastic to start feeds. However, if your patient is still unstable, what can happen is that you have poor mesenteric perfusion and you will have gut ischemia. Remember that in a patient that has gut ischemia, there will be poor motility, poor absorption of the feed, so it wouldn't really help. But there could also be harm in the form of non-inclusive bowel ischemia, creating huge problems. So definitely we would not want to feed patients that are unstable. But once patients are stable, we want to try and feed within 12 hours of the injury. So this is quite a difficult target to reach, because sometimes it takes a while for patients to actually get to a burns unit. And why do we want to do this? Because this hypermetabolic state, the longer you take to feed, the higher the amount of stress hormones will be, and the higher the hypermetabolic state will be. And then there's also our immunoglobulin production. I'm going to go into that a little bit now as well. But also we want to reduce that risk of malnutrition and energy deficit. And we aim to prevent more than 10% of the pre-burn weight loss. And this is quite a difficult target to achieve in the burns units, especially if patients stay for a long time. But we don't feed patients that are unstable. That is probably, that's the most important thing to start off with, is proper resuscitation. And then we have our immune protective effects, and this is the gut-associated lymphoid tissue. So our gut plays a very important part in our immune system, because we have this gut-associated lymphoid tissue, which is actually embedded into the villi of the small bowel, and it helps to protect the translocation of pathogenic bacteria, which can end up with actual bloodstream infections. So this is the reason why we want to try and feed as early as we possibly can, and also want to keep that nutrition going because of the immune protective effect. The immune system in the gut receives its nutrient not from blood, but actually directly from the food that's absorbed. And that's why the only way to keep it healthy is to feed it. So what type of nutrients? So we first have to start with the basics. Often when people ask, what do you think about glutamine? What do you think about copper, selenium? You first have to start off with the basics. So that would include our carbohydrates, proteins, and fats, minerals, and then also our vitamins, and making sure patient gets enough fluid. And just keeping in mind that this metabolic rate is so heavily increased. So it's important to start early, to make sure that you're feeding patients. And how much do we feed? There's a risk of overfeeding as well, because more is not always better. You can end up with liver dysfunctions, increase in CO2 production, hyperglycemia, which all has its own effect on the inflammatory response, and then ultimately increased mortality. But on the other hand, underfeeding can cause a loss of muscle mass as well as weight loss, increase in infectious and infection complications, and poor wound healing. And this is why it's absolutely necessary that you have a dietitian involved in these patients that is calculating the appropriate amount of nutrition that's required. And this is just an example of what could practically happen, because if on paper we might be having the correct nutrition plan, but on Monday, this patient, the feed was off because we're waiting for a pump. And then there was a feed off because the patient's in theatre. Thursday, again, the feed was off because the patient was in theatre. And then patient had to get a new feeding tube because it was blocked. So if you look at it for the end of the week, we've lost 8 hours of feeding, which is quite a significant amount of time. Other things that can also create a nutrition deficit is patients having diarrhea, vomiting, and then multiple theatre days. And it's important to remember that you actually cannot catch up. Once you fall behind on nutrition, it's not just a simple process of putting it back, because remember that you have this 1 kilogram of steak that you're losing every day in terms of muscle in a very hypermetabolic patient. And during critical illness, you won't build that 1 kilogram of muscle. It will have to wait until you get to the rehabilitative phase where patients are off the ventilator, the critical illness part is over. That's only when you can start building muscle again. So what kind of proteins do we give? We need to make sure that the feeds that we're using for burns patients are always a minimum of 20% protein as part of the total energy, and also keeping in mind that there are losses in the urine and in the wounds, and also that the catabolic processes and metabolic response of the patient can become a huge problem. Then there's a specific amino acid called glutamine. Now, glutamine is a very abundant amino acids in our diet, and it's involved with many systems. But during critical illness, it becomes a conditionally essential nutrient. And the reason is because it's part of the glutathione peroxidase antioxidant systems, and therefore you require glutamine to produce this. It's part of this hypermetabolic state that your patient has. Also involved in other systems as well, so it's quite an important nutrient. So when we look at enteral glutamine supplementation in critical ill patients, this is a systematic review that's quite interesting. And you can see in the general ICU population, it had a favorable outcome. When you look at trauma subgroup, there was a favorable outcome as well. But very interesting that the favorable outcome is actually the highest in the burns subgroup. Then the same with mortality, that you have quite a significant positive response for patients receiving glutamine in the burns group, not so much in all the other patients when it comes to mortality. So what about other immunonutrition? So then we can go and start looking at all the other, this is a summary of all the other studies, glutamine, using arginine, using other micronutrients. Your problem is when you look at all of these studies, the doses are not the same. So each researcher chose their own protocol. The combination of some use, for example, glutamine with vitamin C and zinc. Someone else would be using intravenous glutamine with oral vitamin C and intravenous zinc. So it's very difficult to actually put these patients in a meta-analysis. So we are really quite lost. But when it comes to the additional micronutrients, what I would suggest is we definitely need additional zinc, copper, selenium, and thiamine. So we give our patients additional thiamine. We give them zinc and selenium in an enteral form. Copper is unfortunately not available in South Africa as a single nutrient. But what we do is we make sure that the enteral feed that we're using does have at least 1.5 to 2 times the RDA to make sure that you are getting adequate micronutrients. We do give additional vitamin C, and then vitamin D definitely as well. Then the last part is that we want to use the correct route of feeding. Enteral route is our preferred route, and the reason is to keep that gut-associated lymphoid tissue intact. We also want to give a bit of fiber because that helps to keep our microbiome intact. TPN we do use in severe cases where there is feed intolerance as well. But then we get to that point where patients are off the ventilator and the physiotherapists and OT are working quite hard now to rehabilitate them. We all feel we've done such a good job, except we need to make sure that we keep on top of things. Because in the ICU, when we start introducing a solid diet, we often have patients with a poor appetite. They might be vomiting, having diarrhea or swallowing problems. And then we start saying, okay, take out the NG tube because they can eat. And this is actually the point where patients have extremely high protein and energy requirements to be able to meet their physiotherapy and occupational therapy targets. And this is important because it can also make a patient feel very demotivated if they're not meeting their goals that the physio and the OT are asking them to meet. And this is just an example of how a patient ate. You can just have a look there. And if you do a nutritional analysis, only 12% of protein, vitamin D only 6%. And if you look at this and you think of if you're prescribing therapy to a patient and they're only receiving 12% of the dose, this would absolutely not be acceptable. And it should be the same for nutrition as well. So just one last thing that I want to share with you is in our hospital in 2014, we participated in a study where we monitored how well do we feed our patients and how early we do start feeding them. And our average was approximately 5 hours after admission. And the average for internationally was 24 hours. And you can see this is how we were feeding our patients in terms of calories. So by the third day, we were at least at our 80% goal, and we were achieving between 80 and 100% over the next few days. And then the same happened with our protein. And then there's also very important guidelines that can help you. The ESPN guidelines, they have guidelines for burns, for trauma, especially for surgical patients, oncology patients, wonderful guidelines that are free and available on the internet from espen.org if you're looking for any further guidelines on burn nutrition. So in summary, make sure that you have a feeding protocol in place, that dietitians are involved, that we start feeding patients early, that we use our enteral route always as first choice, monitoring patients and making sure that we give supplements when patients require it. Thank you.
Thank you, Chantel, for that very comprehensive overview. I have a couple of questions for you. What do you need to monitor in burns from a nutritional point of view, obviously apart from body weight?
I think that's a very, very important question because just looking at body weight itself, often patients could be fluid overloaded and it might not give you a good indication. One of the things that we do have in our practice is we do have a body composition analysis machine that can help give you a little bit of information about muscle mass. Problem is in burn patients is that you require 4 fingers and 2 ankles that are not burned to be able to do the measurements, which is most of the time a little bit impractical. So other things that we can do is we definitely speak to the physiotherapist to find out how is it going with the mobilization. Is the patient improving on the mobilization? Because that could be a good indicator. Speaking to the plastic surgeons as well, making sure there is proper granulation of the wounds, that wound healing is taking place. We look at our weight as well, and then also looking at some of our other biochemical markers on blood results and just making sure that we are meeting requirements.
Thank you. And quite a contentious one in the burns units, Chantel, is when can the nasogastric tube be removed from a burns patient?
I think it is definitely because
what parameters would you be looking for?
I think it's definitely one of the things that I almost feel like sometimes the doctors feel they want to take everything out, fenestrate, take out the catheter, and we all want to take everything out so the patient looks a little bit more normal. So for me, definitely if a patient has lost more than 10% of their body weight, I would like to keep the feeding tube in. Also, if the physiotherapists and the OT are not meeting their goals for rehabilitation, definitely it's a good plan to keep it in for longer. And making sure that, we're feeding while they're still busy with their physio and their OT until they're slightly stronger before we take it out. And then obviously intake is also quite important. So monitoring, and even a patient might be meeting all those criteria, but if they're not eating well or not managing the supplements well, definitely we would still keep the feeding tube in as well.
Good. And the last question, Chantel, what would you be telling the patients on discharge from a nutrition point of view? What must they do at home once they get home?
Okay, yes. So what I did is, remember in that slide, I did say that patients can have up to a year after the burn injury, they could still have increased requirements. So we do some education with the patients on high protein diets, making sure, for example, that they mixing in a little bit of peanut butter in their porridge, that they eating snacks with protein as well, things like biltong or maybe a peanut butter sandwich that's a little bit more affordable, things like machao in kumas. So we focus quite a lot on protein and making sure that they eat enough protein. We do sometimes also advise a little bit on micronutrient supplementation, but you also have to look at your patient. You know, some of the patients, for example, our workman's comp patients, you know that they probably would not be able to afford extra micronutrient supplementation. So we focus a little bit more on the food, making sure they're eating tin fish, peanut butter, drinking their mas or machao to get enough protein.
Thank you, Chantel. Thanks again.
Thank you.
Our next presenter is Lisa Marie Margraaf, who works for Baxter as a nutrition specialist, and she's from the Free State. Welcome, Lisa Marie.
Thank you very much. Good afternoon, everybody. I'm going to have a quick chat to you about clinical nutrition in burns patients with a specific focus on protein, micronutrients, and indirect calorimetry. And I think it ties in so well with the previous speaker, with Chantal's talk, and I think it's going to link in very nicely and how industry can support dietitians in the field when working with critically ill patients and burn patients. So first of all, let's have a look at why protein is important. So the current challenge is that most critically ill adults receive less than half the recommended protein for the first week or longer in ICU. And as Chantal also said, inadequate nutrition and specifically protein depletion can result in prolonged ventilator time, poor wound healing, increased hospital stay and cost, and muscle weakness, with poor wound healing being top of mind when looking at burns patients. So the opportunities this presents with specifically for healthcare providers is that we're looking to reduce ICU stays, we're looking to reduce ventilator time, and we're looking to reduce muscle weighting and improve wound healing. So what do the guidelines say? Aspen and ESPEN have pretty similar guidelines. We'll look at Aspen first. Aspen set out guidelines for trauma patients and critically ill patients, and I believe this is where the burn patients would fall. So when you look at your protein requirements, it's between 1.2 and 2 grams of protein per kilogram adjusted body weight or actual body weight per day. That's on your left-hand side. And on your right-hand side, ESPEN went a bit further and they specified for major burns between 1.5 and 2 grams per kilogram in adults. So this is a bit higher for your trauma and your burns patients. And that's what the guideline states for protein requirements. And when we look at expert opinion in protein, I'm just going to highlight this one study by Weiss where it was highlighted that early high protein intake is associated with low mortality and energy overfeeding with high mortality in non-septic, mechanically ventilated critically ill patients. So the study design was a prospective observational study of 843 ICU patients, and they ended up showing that in a 60-day mortality, that there was a 40% lower mortality shown in the non-septic, non-overfed critically ill patient protein intake group. So in the end, early high protein intake was associated at day 4 of ICU admission with an approximately 45% lower mortality rate. So higher protein targets really is associated with lower mortality in ICU patients. So this would be obviously in the beginning of your burns patient stay when they are admitted. So optimal protein and energy combined, what is the expert opinion? Because obviously your patient is not only receiving protein, you also have to meet their energy needs. And here we've got on the left-hand side a prospective observational cohort, again by Weiss, where 886 mechanically ventilated ICU patients were studied, and it showed that the protein and energy targets were met when they were met there was a 50% decrease in 28-day mortality this time. So what is optimal nutrition? In this case, it was energy guided by indirect calorimetry and protein of at least 1.2 grams per kilogram per day. And we'll get to the indirect calorimetry part of the talk a bit later. So a 50% decrease in 28-day mortality is quite a significant figure. On the right-hand side, we look at a recent analysis of a large group of data by Zussman et al. That included 1,171 patients with indirect calorimetry data that confirmed that under and overfeeding were both deleterious, and that the optimal amount appeared to be between 70% and 100% of measured energy expenditure. There also seemed to be a correlation between 60-day mortality and protein intake, with a 1% reduction in mortality shown per gram of daily protein ingested. So what does Baxter offer to the clinicians and the dietitians in field? So I specifically focused on the one bag that we have to offer because we are looking at protein. We have the Triomel bag, obviously that's well known in the industry. That is your triple chamber bag, and I specifically made note here of the N9-840 bag with the E showing that it comes with electrolytes, and the one here without the E showing that you have the option without electrolytes. And your nitrogen and amino acid content here, that just shows it has a 9 gram. Both bags are exactly the same. It's just with and without electrolytes. So you have a 9 gram nitrogen, or then if you convert it, 56.9 gram amino acid content. And there it just shows you the with and the without electrolyte content. And just to show you that the bag can be administered to children above 2 years of age. And again, just as Chantal said, when oral or enteral feeding, nutrition is impossible, insufficient, or contraindicated, you do then switch over to your parenteral nutrition. So moving over to micronutrients, why are they important? And yeah, we've got a paper that's well known by Renee Blau, and the purpose of this, or Professor Renee Blau, the purpose of this paper was to assist clinicians to bridge the gap between the available guidelines, recommendations, and the practical applications in the provisions of micronutrients via the parenteral route to adult patients. So international guidelines all agree on key factors that micronutrients are essential components of PN, without which the nutrition provided is metabolically incomplete. And micronutrient prescription should be individualized to the clinical requirement of the patients, and micronutrient status should be monitored in long-term PN patients. I'm not going to read through all of this, but the panel did reach consensus on a lot of important issues surrounding micronutrients, and that the highest risk, this stood out for us in the industry and for me as an individual, that the highest risk regarding routine doses is not delivering them at all. So what do the guidelines say? First of all, consensus recommendations for micronutrients administration to parenteral nutrition, and Aspen, Orspin, and Espin highlight the need to provide micronutrients daily in conjunction with parenteral nutrition to prevent development of deficiencies. And Espin, Orspin, and Aspen just basically put it a bit differently, and they specify, when one looks at individual vitamins and micronutrients, they specify slightly different amounts if you look at the details. When we look at the expert opinion on micronutrients, micronutrients are a critical component to nutritional provision and parenteral nutrition, provided without them pose a considerable risk to nutritional status. Obstacles to their daily provision include voluntary omission. So sometimes in practice, they are omitted. Partial provision, so maybe not reaching adequate dosages, and supply issues. And that must be overcome to allow safe and responsible nutrition practices. So what about burns patients specifically? So in this paper by Professor Renee Blau, the panel reached consensus that there are obviously 3 stages: your early resuscitation phase, your wound healing phase, and your recovery and rehabilitation phase. And in those 3 phases, the patient has different and specified needs which must be met. But in general, the recommendation is that if PN is not administered, IV micronutrient repletion may be needed depending on the magnitude of the burns. If a patient is on parenteral nutrition, doses provided through standard multiple trace elements and multivitamin supplementation are sufficient for smaller burns, less than 20% of body surface area. Apologies for the spelling mistake. And higher multi-nutrient doses are required for major burns, independent of nutrition route, and IV multi-nutrient repletion may be warranted. So independent of parenteral nutrition, supplementation might be warranted. So I'm going to just provide you with some food for thought regarding micronutrients. And this revolves around vitamin instability in parenteral nutrition. So vitamins are commonly believed to be the least stable ingredients in parenteral nutrition mixtures. And PN may contain over 40 ingredients and is considered a high alert medication because significant patient harm may occur when this therapy is used in error. Vitamin stability is limited in the presence of temperature, light, and certain trace elements, with vitamin C being the least stable with a rapid degradation within 24 hours. So for stability reasons, vitamins are not included in all commercially available parenteral nutrition bags, and they are sometimes added separately immediate prior to infusion, and that explains the existence of your 3-chamber bags. So in terms of micronutrients, what does Baxter offer? We offer a product called Cernivit, which I'm sure everybody is well familiar with. It has been in existence for quite a few decades. It is a 12-in-1 multivitamin supplementation. You can see at the bottom here exactly what the composition is. It's got quite a comprehensive composition. It contains the necessary water and fat-soluble vitamins, excluding vitamin K. We thought to be rather on the safe side and not interfere with the patient's coagulation cascade. It can be administered intravenously or intermuscularly. I'm just quickly going to explain to you the IV route for administration. IM has a slightly different reconstitution. So for IV, you would inject a 5 ml water for injection into the Cernivit's vial in order to just reconstitute and dissolve that powder. Our, let's call it, top tip is not to violently shake the vial. That might cause it to bubble. Rather just swirl it gently and then administer it by slow IV infusion into a saline or a glucose bag. And then our very proud addition to the Baxter family, we're looking at indirect calorimetry. So what is indirect calorimetry and QNRG+? So indirect calorimetry is a validated century-long study technique that measures resting expenditure in patients with various pathologies, either during spontaneous breathing or mechanical ventilation, to optimize nutrition support in acutely ill or chronically ill patients. The QNRG Plus monitor is the device that accurately measures the difference of concentrations of O2 and CO2 between the inspired and expired gases and the flow of the gas. Energy expenditure is then calculated using Weir's equation. So why is indirect calorimetry important? So as you can see on the left-hand side, energy needs vary by patient. So this is the kilocal per gram per day of different types of patients in the ICU. You've got your burns patients, your critically ill patients, your sepsis patients. So these are your multiple trauma patients and your brain injury patients. So this is just how 2 different burns patients differ in terms of their calorie requirements, and different sepsis patients differ. So you can see there's quite a varied degree of variance between their energy needs. So this really explains to us that patients' needs differ and their energy requirements needs to be individualized. So indirect calorimetry gives you the opportunity in 4 easy steps to individualize your prescription by assessing, first of all, your patient's needs, by then prescribing the correct dosage, by then delivering your nutritional prescription or your feed, and then again by monitoring what you are delivering to your patient to ensure that they are actually getting what you are delivering. So what do the guidelines say with regards to indirect calorimetry? We've all known for a while that indirect calorimetry is the gold standard to accurately measure energy expenditure. So again, ESPEN and ASPEN lists it as the first line method for measuring your patient's energy expenditure, and it's quite a strong recommendation by all of them. Obviously, there are different phases during your patient's stay in ICU, and they have different recommendations of how you would then feed your patient or how you would then use the information gathered from your QNRG device, and we recommend that you follow the guidelines accordingly. So in terms of indirect calorimetry, what does Baxter offer? Baxter, in partner with Cosmed, offer the QNRG Plus device. So it can be used on ventilated patients and spontaneously breathing patients. And the device has really been, I almost want to say fitted, and it's next generation technology to make the clinician's life quite easy in today's world. So it can be used at point of care. It weighs less than 5 kilograms, and it can be easily transported between patients and even between different wards to individually assess a patient needs. It is extremely accurate to ensure that your patient really gets what they need and that their energy calculation is correct. And in terms of speed, there is a learning curve when one initially introduces it into your ward or into your ICU and in your hospital. But when one is up to speed with how it works, a test can be done within 10 to 15 minutes. And calibration only needs to be done monthly. And ease of use, it literally at the touch of a button, once everything is connected, your test results are available to you. So it really does help to deliver optimal individualized nutrition. So what is our call to action for both us in the industry and clinicians in field? In terms of protein, we feel that early high protein can make a difference, and the goal of appropriate nutritional support is to supply the required amounts of energy and protein to your patients. In terms of micronutrients, parenteral nutrition is not the only indication to prescribe IV micronutrients, and prescribers need to recognize other high-risk groups like your burnt patients that also necessitates additional micronutrients. And for indirect calorimetry in the daily ICU workflow, implementing that in your daily ICU workflow can really help you to assess your patient's individualized needs through 4 easy steps to achieve optimal nutrition. I thank you.
Thank you, Lise Marie, for sharing your extensive product knowledge with us. It's very illuminating. Thank you.
Thank you.
Thank you. My name is Moira Wilson. I'm a physiotherapist. My practice is situated in Mill Park Hospital. We deal with mainly trauma, burns, and neurosurgery and neurology patients. Ready to go. So burns are a global health problem, and they're the 4th leading cause of trauma worldwide, according to the American Burn Association. They're very complex patients to manage due to multiple areas being burnt and many different body systems affected. Due to the recent advances in critical care, more and more patients are surviving. This is great, but the burns patient has survived probably one of the most traumatic events in his life and now potentially has severe sequelae of burns to deal with. For example, pain, pruritus, restriction of joint mobility, physical weakness, and poor endurance. So focused rehabilitation is more important than ever due to the quantum of burns patients with high TBSA surviving that previously would have demised. Quite a staggering was Mike Peck's work telling us that infants in Africa have an incidence of fire-related burns 3 times the world average. That is huge. So the burnt patient is if he's left with severe scarring, it's a leading cause of disfigurement, disability, and it reduces his quality of life. Not just his earning capacity, but also his leisure activities and maybe previously enjoyed hobbies that he's not able to pick up because of scarring or pain or some of the items we've mentioned before. Remember, the ultimate aim of burn care is to achieve wound healing as quickly and completely as possible. This is to reduce the likelihood of hypertrophic scarring. If the wound heals in less than 21 days, there's less likelihood of HTS developing, although there are other factors at play. You can change the slide, thanks. Burn rehab starts on day 1. Even if the patient is quite sick and ventilated, it's important to start chatting to the family as soon as possible so that you can manage the expectations from the word go. The rehabilitation will be dependent on various factors, for example, the type, the area, how stable the patient is, his age, the depth and the extent. It's really important, though, to know the condition of the patient pre-morbidly. How is his level of functioning physically, mentally, and emotionally? This will guide us as to what our expectations are. It's important to be aware of any comorbidities that might affect our rehabilitation. And we also need to know if he uses walking aids, hearing aids, glasses, or contact lenses. And in fact, there is a complex relationship between pre-morbid mental health and the selection of his coping strategies that will affect long-term outcomes. The multidisciplinary team is spoken about a lot, particularly in burns. It allows professionals to collaboratively care for the patient, working together closely to overcome the unique challenges of a severe burn injury. Many different disciplines are involved in the burns patient, not limited to the ones listed below. In fact, there's play therapists, art therapists, there's many different people involved, but you can see it's a huge resources working together to get optimal outcomes. Thank you. You can turn. I think what's maybe not always, sorry, go back one. What's not always obvious is that the patient is a vital cog and his family are vital cogs in the rehab process. It's important to include them for day 1 to achieve the best outcomes. No other medical condition requires as many different professionals interacting for optimal results over such an extended period of time. A good analogy that I like to think about is a wheel with the patient at the center of the wheel and the spokes of the wheel being the healthcare professionals converging into the center. We need to build trust between all members of the MDT and the patient. And we use SMART concept for goal setting, which is specific, measurable, achievable, realistic, and timely goals. It's important to do this from day 1. Basically, every single aspect of the patient's life is controlled by others. When he sleeps, when he eats, when he gets up, every single aspect of his life is controlled by others. So if we can give him back some power with self-feeding or ability to roll over, then it goes a long way to feel that he's part of the process. We must think more of the care being patient-centric. He needs to be empowered to play an active part in his recovery process, because he's going to have to continue this even after discharge, because he may be living with the sequelae for many years to come, depending on the degree of injuries that he has sustained and the side effects from burns. Yeah, you can turn. So basically, to self-manage his condition, we use things like this. So it's very important for a burnt hand that you get flexion at the MCP joints. So this is a stretch that we give the patients to do. The minute you give good MCP flexion so that the collateral ligaments on the side of the MCPs are on full stretch. Otherwise, they tend to do that, and that's not a very functional hand. So we teach the patients to do this self-stretch every time they get out of bed to go to the bathroom, thereby encouraging them to take ownership of the process. Thank you. A patient said that there's many pillars of successful burn rehabilitation. There needs to be good collaboration and communication between all members of the MDT so that we can plan treatment sessions around patient dressings, theatre times, adequate pain control. Goal setting from early on is very, very important, as we spoke about. Even small things, the fact that he can feed himself, the fact that he can get up on the edge of the bed, it's massive for the patient. We need patient and family buy-in from day one. Positioning is a huge one. We need special attention to the face, and this is everyone's job. Neck, hands, including thumb, web spaces, and digits. Sometimes we have a bit of a problem because with pillows, it doesn't look nice if the patient's lying in bed and the pillow's taken out, but we need that to ensure stretching of the anterior neck structures, especially if the anterior neck areas are burnt. The pain control needs to be very good. We need good quality nutrition as early as possible, as heard from by Chantel. We need splinting, either static or dynamic. We need graded functional staged exercises, graded early mobility out of bed. We get them out of bed as quickly as possible. Psychological support is important. Sleep hygiene is important. And activities of daily living to encourage self-feeding. We use things like long-handled cutlery to enable the patients to self-feed. And then discharge and follow-up planning is very important. Thank you. There are barriers to successful rehabilitation. Poor understanding of the long-term implications of this devastating injury, resulting in suboptimal compliance long-term. We need to know how his health is pre-morbidly. If he has inadequate pain control, this will hamper rehabilitation and we won't get out of him what we need to get out of him. There could be a language barrier. Often burns patients have low mood, apathy, and more than 50% of burns patients suffer from PTSD. A lot of the patients also have inhalation injuries, lung damage. They're slow to rehab. They need to be mobilized perhaps with a pulse oximeter. They have multiple anesthetics, surgeries, and grafts. And adults in hospital with a burn injury have a worse cognitive FIM score. A FIM is an outcome measurement tool which measures various aspects and allows us to give them a score. But with the burns patients, this is a recent study that was published in Burns, who said that the rehab populations, the burn rehab population's memory is the most affected. So that would make sense as to why we need to constantly reassure and explain to the burns patients. Sometimes daily, you have to explain everything about the injury, what's going to happen forward. If they're forewarned, then they're forearmed. Another barrier is limited staff resources, time-consuming, long-term patients. They take a long time. There's a lot of resources spent on the burns patient, dressings, turnings, physio, OT, very resource intensive. Okay, you can turn. These are important concepts in successful rehabilitation, and in any successful rehabilitation, not just a burns patient. So put them round in a circle, picking up the wheel story again, just to emphasize on that. And cognition, we start with cognition. Cognition is important. They need to understand what you're saying. They need to be able to communicate, understand, collaborate, cooperate, and comply. All of the above are interdependent on each other for successful rehab. If one of these areas is lacking, then it makes everyone's job more difficult. The patient needs to have good cognitive ability to comprehend what's being communicated to him. He needs to collaborate and cooperate with other members of the team to ensure good compliance with his program. You can turn. Pain in the burns patient. I can't emphasize enough how important good pain control is in achieving maximum cooperation and compliance from this patient. Pain control is one of our biggest challenges. If not addressed properly, then rehab will be affected and the results will be suboptimal. The burns patients always have background pain, which is often continuous in nature. Then we come along and do our procedures, which gives them even more pain. We need collaboration and cooperation with members of the MDT to collaborate when the drugs are getting done, when the physio is happening, when the OT is coming, when the dressings are being done. The pain ladder from the World Health Association is useful. Start with step 1 and then you climb the ladder. We use the VAS scale, with 1 to 3 being mild pain, step 2 moderate pain, step 3 severe pain. Can be multimodal as well. Adjuvants can be used to calm fear and anxiety. And gabapentin and pregabalin may lead to reduced opioid usage and reduce the pain intensity. Thank you. Prior to some of the collaboration that we have with the MDT, some examples now. So prior to physio, it's important that he has eaten and ready for physio. The nurse ensures that he has eaten sufficient prior to exerting himself. Otherwise, his mood and energy will be low, which impacts his performance and endurance. Dietitians often request that the physio assist the patient to be mobilized to stand on a weighing scale for more accurate weight measurement. At times, the physios request the nursing staff to treat patients when the hands are exposed. The nurses will call the physio to the unit if she's not in the unit at the time. If the patient is very young or anxious or they're struggling with their physio, the physios are able to go into theatre, and our plastic surgeons are quite happy about that, to treat them under anaesthetic. It's less stressful for the patient, you can get better range of motion, and the physio can get a lot more done when they're under anaesthetic and pain-free. If we do that, then we generally give them the next day off physio, as well as if they go for a very deep debridement. We normally give them a day off, because that builds trust between the therapists and the patient. They need to understand they're part of a team, and we're not just bossing them around and making them do all sorts of things and causing pain. There's good coordination of the timing of the mobilization of the patient to the chair to facilitate OT and speech therapy. And we like to stand the patient early so that the nurses can change the bed linen. It's less traumatic than rolling and moving him up the bed. Assessment of swallowing ability is easier in the chair as well. And in face and neck burns, phonation can be affected and make it difficult for the patient to be understood. Salivation can also be a problem. And swallowing and feeding. If his requirements nutritionally are not met, he'll be slow to exercise, progress will be poor, and it will prolong and protract his length of stay in hospital and adding to his costs. Can change. So basically, usually one discipline, there's studies done on one discipline, but this is the first study that's published in Burns this year about the effects of physio and dietetic collaborations. So early mobilization and early enteral feeding are two of the most important treatment therapies for optimal recovery. So if the patient is doing resistance training, exercising with weights, the physios have been taught to give them his protein drinks immediately after exercise, because there's a better uptake of protein to the muscle after strengthening exercises. And in fact, this study showed there were significant correlations between independent mobilization and diarrhea, independent mobilization and albumin, length of stay and diarrhea. So regression analysis showed that the hours taken to commence enteral feeding predicted diarrhea, which is what we don't want. Thank you, you can turn. So positioning is very important, and it's everyone's job in the MDT. Often the patients try to play one member of the MDT off against the other. So if we look at this slide in particular, anterior neck burns are extremely challenging. And if the neck's allowed to contract, we have problems with salivation, as said before, vocalization, speech and feeding, which will affect his quality of life. Even when the patient is ventilated, we need to watch his neck position, and we want to commence facial exercises and stretches early. The pillows, we like them out and in every couple of hours to get that stretch, and we combine the neck and facial exercises together, because if when we exercise the neck, we can see if the mouth happens to pull down on the side. And if you're doing your exercises and extending the neck over a pillow, keep the mouth closed, because then you've got a maximum stretch on your anterior neck structures. But positioning, the patients will try to play one off and say, no, the other physio says I can have the pillow in all the time. So just be aware that that's one of the problems in burns patients particularly. You do tend to play one therapist off against the other. So basically, the face and neck mobility is very, very important. We need to pay attention to the restriction of mouth opening. We can use a wooden spatula to get the mouth to open, and we measure the centimetre. That's a goal set for the patient. You can pad the spatula and slowly but surely try to increase his mouth opening gradually. Mouth closing is also important. If the lips are swollen due to burns, it impedes the mouth closure, and you can't really swallow if you can't close your lips. And then he drools everywhere and he's embarrassed, and it's not nice. So mouth closure and tongue movements are vital for clear speech, swallowing and eating. Eye closure is also important to prevent corneal damage. If the eye doesn't close properly, then suggest an eye patch at night or tape the eye closed. When practicing the neck movements, keep an eye on the mouth and eye area to ensure they aren't being affected due to cervical restrictive tissues. So when you're doing your mouth and eye and neck, keep an eye on all things together. And facial exercises and stretches can be carried out religiously, must be carried out religiously and frequently to lessen contractures. We like to encourage chewy sweets or chewing gum to improve oral tongue and face mobility, and encourage drinking from a straw to practice and achieve lip closure. Thank you. Any questions? Thank you. Our next speaker coming up is Evanthea. Evanthea is an occupational therapist who graduated as an OT from WITS in 2005. She did her community service, and then she worked at Steve Biko for 4 years in the ortho unit with specialist orthopods and plastics, covering upper limb trauma and burns cases. She completed her master's in occupational therapy, cum laude, specializing in hand therapy, and in 2011 she commenced private practice. Together with her business partner, Roxanne Wenzel, they started Joburg Hand Therapy. They have practice sites in multiple areas, but also in the Mill Park Burns unit. Since 2013, she's been affiliated with an international organization named CUTE Project. It's an NGO which runs yearly surgical missions in various African countries, including DRC, Uganda, and Benin, assisting with the management of children and adults with burns, as well as training healthcare professionals. Welcome, Evanthea.
Hi, Moira. Thank you so very much for having me. Can everybody hear me? I'm going to take that as a yes. All right, I'm Evanthea, and I'm going to be talking on the management of the burnt hand. So burn injuries constitute a large proportion of morbidity and mortality in the world, and Africa's statistics contribute largely towards those numbers. Many Africans fall victims to their own poverty and poor socioeconomics, such as the boy that we see on the right-hand side who fell into open flames while at home and sustained burns to his face, torso, and hand. Other reasons or causes for burns are work-related injuries with patients exposed to thermal, electrical, or chemical burns. So that's important to bear in mind, the causes that lead to burns and the burns that we see within our context. Okay, so as Moira mentioned, the MDT team is super important, and optimal acute management is very much dependent on a multidisciplinary approach with medical professionals as well as allied professionals working together in order to promote and restore function, and as Moira said, get wound healing as quickly as possible in order to ensure an optimal outcome. So when we look at a patient with a burn injury, and specifically a burnt hand, we need to consider a number of factors. So we need to understand the degree of injury and skin integrity, and that's important for the healthcare professionals from a medical point of view, which will determine the type of medical intervention, whether a patient needs skin grafts or not. We need to look at edema, because edema has the potential to shift joints into very deforming positions, which can result in the development of contractures. We need to understand whether burns extend over joints, because once again, those can lead to the development of contractures. We need to assess passive and active range of motion, and we need to understand the phase of healing that that patient is in, because that will very much direct how we intervene and the degree to which we intervene, so that we are not causing damage, but in fact helping the patient to recover. We need to understand, does that patient have sensation? From a twofold perspective, number one, the degree of injury obviously might cause damage to those sensory nerve endings, but also if we have patients with electrical burn injuries, often their nervous system is affected and their nerves are affected, which may result in a loss of sensation. So when we are deciding how to intervene, we have to understand what phase of healing a patient is in. Are they in an acute inflammatory phase? Are they in a fibroplasia phase or a scar maturation phase? Because that will determine how we intervene and the degree to which we can push and mobilize joints. So we understand that in the acute inflammatory phase, we have increased edema and a very large cellular response. And as we move into the fibroplasia and scar maturation phase, we get greater synthesis of collagen and laying down of collagen fibers. So as occupational therapists and physiotherapists, it's important, I think, when we are managing patients with burnt hands and burns throughout the body, in fact, to understand what exactly can go wrong. Because I think once we've seen what can go wrong, it can better assist and direct us in terms of what to do in order to prevent things from going wrong. So, for instance, if we see a patient with burns on the dorsum of their forearm, wrist, or hand, we need to understand that there's a potential then for a development of an extensor contracture, such as what we see on the right-hand side. And so then we need to intervene in a way that will prevent that from happening. Again, if we see a patient with a burn on the volar surface of the hand, then we understand that there's potential for development of contractures over the PIP, the DIP, MCP joints, and even the wrist, and even pulling that thumb into adduction. And so we need to intervene so that we can prevent that from happening. At times, we have patients with circumferential burn injuries, and that can be quite complicated because we have potential for both extension and flexion contractures, which can develop. And so then we have to very much use our clinical reasoning and monitor the patient's progression through their recovery to understand what is actually happening to each of those joints and how do we counter it if we don't want that specific contracture to develop. Similarly, if we see a patient with burns over the anterior aspect of the elbow, we understand that there's a potential for a contracture of a flexion contracture of the elbow to develop, which would limit that patient's potential to reach during function. And so we need to counter that by perhaps introducing range of motion exercises or a splint which maintains extension in that elbow. So ultimately, our goal is to maintain and restore maximum function in these patients. So when we're looking at treatment in the acute phase, we look at educating the patient, reducing edema, positioning, maintaining range of motion, and restoring participation and independent participation where possible in activities of daily living. Education, as Moira mentioned, is a really, really important aspect of our treatment, because if we have that patient's buy-in, it means that their outcomes are going to be potentially many-fold much improved. As we all know, resources are limited, and as therapists, we can only see a patient once or twice a day. But we do know that the more work that patient puts into their own recovery, the better their recovery will be. So in terms of management of edema, we have many kind of tools in our arsenal to be able to help. The first one would be elevation, which facilitates drainage of fluid by action of gravity. Gentle active range of motion, and note I do mention gentle because aggressive active range of motion would actually cause greater edema, but gentle active range of motion causes a muscle pump action which stimulates movement of fluid back into the circulatory system. Rest and splinting are really important because if there's too much movement, there will be an inflammatory response which occurs, which counters what we're trying to achieve. So rest and splinting are important in reducing inflammation and facilitating drainage of fluid back into the circulatory system. Compression is really, really important because it mechanically forces fluid out of the tissues into the circulatory system. And more often than not, we see patients that are bandaged post-op from theatre in this mitt type of a hand. And I do understand that it's really difficult to dress a hand adequately and appropriately. But if we can get to a point where we can achieve dressing of hands, such as what you see in the image on the right-hand side with individual finger movements, not only are we getting individual compression on those fingers, addressing edema, but we're opening up an avenue for that patient to be able to mobilize their hand, to be able to grasp and pinch and start to use their hand, which allows for greater participation in activities of daily living. Positioning is super important. It helps to minimize edema, maintains the optimal position of soft tissue, it reduces tissue destruction, and it aligns our joints. So as Moira mentioned, we like to keep the MP joints in flexion so as to keep the collateral ligaments elongated. The wrist should be placed in slight extension and the IP joints in extension. Now, as well as the thumb in palmar abduction. Now, this is the safe position of the hand, and it is the position we would splint a hand that has, number one, burns on the dorsum of the hand or circumferentially. However, should you come across a patient who has burns solely on the volar surface of the hand, you would want to place the hand in extension because you want to place the tissue that's injured in its lengthened position. That's not to say that this patient would be in full extension over a very prolonged period of time. In fact, actually that splint would come off quite often to allow them to mobilize, but during rest periods, we want to maintain the length of those tissues and we want to prevent flexion contractures from coming in. So although counterintuitive in many people's minds, you would want to place the hand in full extension. Range of motion is one of the biggest aims in recovery of hand function, particularly in a burns patient, with a goal to preserve function and prevent deformity. We need to bear in mind the precautions, however. So if we do know that there is underlying tendon involvement or if there is a recent graft that has been put in place, that we cannot just mobilize. We need to understand that those tissues need time to settle. So before mobilizing, we need to get the kind of go-ahead from our surgeons that we are safe to mobilize. And we're looking at active range of motion and passive range of motion, bearing in mind, again, those precautions. So when we do active range of motion, we need to mobilize all of the joints, the wrist, the MCP joints, the PRP joints, the DRP joints, as well as the thumb at the CMC, MP, and IP joint. We need to do movement in isolation, which addresses the joint directly, as well as composite movements, which address the muscles that allow for movement in those joints and lengthens those muscles. And we also need to do what we call tendon glides, which allow for differential glide of flex and extensor tendons. Once again, as Moira mentioned, the buy-in of the patient is really, really important. So getting the patient to mobilize actively independent of the therapist is really important because what we do know about tissues is that a lesser force over a prolonged period of time, so in other words, more often, will have a greater effect than one mobilization regime a day, which is a little bit more aggressive. So getting that patient to buy in and showing them how to do their ward exercise program is really, really important. Ultimately, our goal is function, and we can really achieve our range of motion aims through function. So for instance, in the image that you see in front of you, the patient is holding that toothbrush. And in order to hold that toothbrush, he needs to be able to flex the PRP and the DRP joint of the index finger as well as the IP joint of the thumb. So not only are we achieving our aims from a range of motion perspective, but we're also getting that patient to be a little bit more independent in their activities of daily living, which also motivates them and gives them just an avenue of maybe I'm going to be okay. I can do these things. Splinting remains one of the biggest roles that OTs particularly can contribute in the management of the burnt hand. And what we understand about a scar is that an active scar or skin graft will continue to contract until it meets an equal and opposing force. And that was said by Gabbiani, and that's where splinting comes into play. Now we have a number of splinting or different types of splints in our arsenal to be able to kind of assist a patient with a burnt hand. But the type of splint that we do decide upon will be very much dependent on the phase of healing that that patient is in. So in the earlier phases, the inflammatory phase, we'd be looking at static splints, which really look to just immobilize in a functional position. And as we move into the fibroplasia scar maturation phase, we'd be looking at dynamic splints or static progressive splints, or what we call SIMS plaster of Paris, which would look to apply greater forces in order to push joints into directions that we would like them to go in towards. So this is an image of a static splint, which maintains the functional position of the hand and negates the effects of edema. It provides a gentle stress, which orientates collagen fibers. More often than not, because of edema, we can't always get the patient into the best functional position. And in those instances, what we can do is start off at a certain point, and as the patient becomes more comfortable in that position, then we can take that splint, remold it, and get a greater functional position or more optimal functional position. As we move into fibroplasia phase, we can start using what we call dynamic splints or static progressive splints. And dynamic splints use elastics to hold the joint at its in range of motion. And so with a dynamic splint, a patient can move against that motion, so back into extension, but when they relax, that dynamic splint will hold them in flexion, allowing for elongation of soft tissue in the direction that the therapist so chooses. When we look at static progressive splints, they work very much in the same way. However, they don't have a dynamic component, so the patient can't oppose the movement, but it just maintains the total end range or total, it maintains the joint at its total end range. I'd like to talk to you a little bit about what we call SIMS. It's casting motion to mobilize stiffness, and it makes use of plaster of Paris, which is a very old technique to create mobility in a limb. And it works on a twofold basis. Number one, cortical remapping, and number two, it immobilizes joints more proximally to allow for movement more distally and redirects the force of muscle action to the joint that we would like to have moved. So in the image that you see, this little boy had a contracture of his MCP joints into extension, and we were looking to recover flexion. So what we did is we immobilized his wrist and we blocked him from being able to extend, so that the force of action of all his flexor tendons was moved towards flexing his MP and IP joints into a fist, thereby also reorganizing the way his brain works his fingers, so that we're not getting movement at the wrist and into extension, but more towards flexion, and also redirecting the force of muscle action. The other element of our treatment is scar management, and the way we address scar management is through massage, compression, the provision of silicone treatment, pressure garments which apply the compression, and also not forgetting massage of donor areas. So this is an image of a patient who had bilateral burns to her hands. In the image in the middle, you can see the pressure garments that were provided for her, and several months later, you can see that the effect of those pressure garments were such that the appearance of the scar is much better in terms of the color, in terms of the softness of it, and how swollen it is. And we know that we can continue to effect change with pressure garments for up to 2 years, or at least as long as that scar is still maturing. Obviously, the earlier their intervention, the better, but even up to 2 years, if that scar is still active, we can still effect change. It can still all go wrong. So even if we do our very best and we have the patient's buy-in, often they go home with full range of motion, with a splint, and then they still come back with a contracture. And so in the image that we see, this little boy had burns over the dorsum of his forearm, wrist, and hand. And he went home with full range of motion, but came back a week later. And in the image in the middle, you'll see that's his extension ability. And in the image on the right-hand side, that's his flexion ability. So you can see that he has a contracture of his MCP joints into extension, and that he can't actually flex those MP joints. Now, a lot of people think this patient needs surgery again. But if we intervene optimally at the right time, we can manage this patient conservatively as we did and restore his function. So this is the patient we saw earlier, which I put in a SIMS cast, and we sent him home. The benefit of the cast was that he wasn't able to take it home. He wasn't able to take it off at home. And any movement that he did achieve was to achieve MP joint flexion and IP joint flexion. And so we sent him off for 2 weeks, and he came back, and this was his hand 2 weeks later after we took off the cast. So really, if we do understand what to treat and how to treat it, we can avoid many patients from having to go back into surgery for secondary operations. Once again, our optimal goal is function. So it's really, really important that when we are managing these patients, that we understand what is significant and important for them, and that we introduce functional activities that are relevant to that patient in order to restore function. As we mentioned, Roxanne and myself are involved in a huge project, which is an international NGO of physicians and doctors and surgeons and nurses from Italy who are involved in kind of carrying out surgical camps in different African countries once a year. COVID has put a little bit of a spanner in the works, but they're a great organization, and Roxanne and I are involved in the allied aspect of that and the rehabilitation of that. They're really a great organization, so I would encourage you all to give them a squiz on over the internet and Google them so that you can see what they do. Thank you very much.
Thank you, Eventhia, for that lovely talk. I'm just curious, when you do your traveling with and you go to all these far-flung places, not so much Benin, but the African countries, do you just take pressure garment stuff with you and splinting stuff and just do what you can, basically?
So what we do is we kind of speak to kind of the companies that we get all our splinting material from and our pressure garment material, and we kind of procure as much material as we can, and we take it off, and we take it off with us to those countries. And really what we do is we try and train the locals to do what we do. So we work with them and we train them, and we leave whatever material we can over there, and as they need more material, then we send off to them. Obviously, it's more on the pressure garment side. In terms of splinting, you really need to know what you're doing in order to splint. So we aren't keen on leaving the splinting material unless we're quite confident that the people that we're leaving the material with know how to use it adequately, because we obviously don't want to cause harm. But from the pressure garment side, we've really done well in terms of training the locals to be able to make pressure garments. And in fact, the image which I showed you in terms of those pressure garments with the lady with the bilateral hands, that wasn't made by me. That was made by a nurse in Uganda who had made those pressure garments for a patient, and that was the result. So it's really working.
Well, that's great. It's great that you're able to impart that knowledge to the local people so that they can help. They can help the locals, because you can't be running up and down there all the time.
Exactly. Yeah.
If they understand the concepts, then that's great. Thanks again, Eventhia. Thank you so much.
It's my pleasure.
Good. Next, we're going to have a few videos from our sponsors.
Our world is rapidly changing. Around the globe, communities are developing new ways of managing their life, work, education, and health. Coronavirus has rapidly driven change, transforming how we connect and interact with our healthcare. When it comes to the needs of wound patients, though, some things are not working well. Despite innovations in treatment, patient outcomes are still less than ideal. Wound patient numbers are still increasing, impacting working-age adults as well as older people. Budget pressures are making it difficult to access more effective specialist products and care. Inconsistencies in diagnosis are compounding these issues. We understand the daily challenges you face managing patients with wounds. Together, we have the opportunity to establish new standards of care. We're seeing greater adoption of early intervention strategies with opportunities for further innovation in patient-led care. At Smith & Nephew, we're committed to improving the lives of patients. Alongside our customers, we won't settle until we've solved the challenges of preventing and healing wounds. Because they hold back too many lives. We're developing better ways of improving outcomes for patients, ensuring the right treatment for the right wound. We're continuously searching for ways to improve how care is delivered. Your challenges are our challenges too. By meeting and exceeding you and your patients' needs, we can make real change. Continually shaping what's possible in wound care.
Acticoat, nanocrystalline silver-coated antimicrobial barrier dressing range. Acticoat barrier dressings demonstrate clinical efficacy in the treatment of infected wounds. At first glance, Acticoat dressings may appear to look similar to other silver barrier dressings, but deep within the structure we can see why Acticoat nanocrystalline technology is so unique. The deposition of silver impacts the efficacy of the dressing. The more silver that is available in a dressing, the more pathogens can be killed. When we look more closely, we can see there is a visible difference in the silver coverage of Acticoat dressings compared to other silver dressings. On an Acticoat substrate, there is a continuous coating of silver, compared to other silver barrier dressings that show a less dense deposition of silver. Nanocrystalline silver has a high surface area, so can achieve a sufficiently high Ag+ concentration to be rapidly bactericidal in the presence of wound fluids. The unique construction enables more silver to come into contact with the wound fluid. Within 30 minutes, positively charged silver ions come into contact with bacteria, disrupting the cell wall and cell membrane, denaturing the proteins and enzymes, preventing respiration and inhibiting DNA synthesis, resulting in cell death. The challenge with the use of low-dose silver dressings is that active silver binds to many components found in wound fluid, such as RNA and DNA, chloride ions, devitalized tissue, proteins, and other organic material. This leaves little to no available Ag+ to kill bacteria. So it's important that the silver dressing delivers enough silver to sustain the Ag+ concentration needed to be bactericidal. A marked difference in the speed and extent of kill was observed. This example shows EMRSA. As the bacteria die, they turn red. You can see how quickly and effectively Acticoat starts to kill. Acticoat has broad-spectrum antimicrobial activity and is proven effective in vitro against a broad spectrum of gram-positive, gram-negative bacteria and fungal wound pathogens, including strains of MRSA. Acticoat makes a real difference to patients. It reduces bacterial burden, helps prevent progression of wound infection and wound invasion, leads to faster reduction of clinical signs of infection, has less risk of resistance, is proven to provide an efficient antimicrobial barrier. Acticoat barrier dressings come in various different formats, which all contain nanocrystalline silver. Flexible, absorbent, or conformable, each Acticoat variant is developed with properties specific to its required use. Acticoat broad-spectrum antimicrobial barrier dressings with unique nanocrystalline silver are proven to prevent and treat wound infection.
Have you ever noticed that whenever a medical breakthrough is achieved, people call it radical, revolutionary, unprecedented? At 3M Healthcare, we call it something different. Science. When a surgical procedure goes well with less risk of complications, 3M is there. When a person is able to look at themselves differently, 3M is there. When the right care is administered and lives are restored, 3M is there. When a doctor can put the keyboard down and instead focus on their patient's every word, 3M is there. Even when a family sits down to a nice meal together, 3M is there. Armed with a passion and commitment to science, 3M Healthcare is helping make better health possible for people next door and around the globe. Science is our pursuit. Improving lives is our purpose.
There's more than one type of wound. Some can be healed, some can be prevented. Some can only be managed. Because there's more than one type of wound, we need more than one type of solution. When it comes to the healing process, one size doesn't fit all. Your patients are dealing with unique challenges. And while you're helping them, we are helping you. We are standing by your side 24/7, so you'll receive the support you need. We are offering extensive world-class education and training, so you can feel more confident in the latest products and techniques. We are creating innovative solutions designed around your challenges and needs, so you can help improve the outcomes for all your patients. Patients with wounds that need to be treated with negative pressure wound therapy. Patients with closed surgical incisions that need to be protected from surgical site complications. Patients with chronic wounds that need ongoing care and management. We are doing it together. The people behind the curtains, the people behind the technology. We are transforming healing. And we're doing it with science.
Elise is used to treating patients with acute or chronic wounds with VAC therapy. Today, a new clinically effective therapy exists, VAC Veriflow therapy. It combines the benefits of VAC therapy with the benefits of instilling topical wound solutions to clean and moisten the wound. Elise can choose from different types of foams depending on the wound. For example, in the event of sloughy wounds, when surgical debridement may be delayed or is not appropriate, the VAC Veriflow Cleanse Choice dressing facilitates the removal of thick exudate and infectious materials thanks to its honeycomb structure. Elise applies VAC Veriflow dressings in the same way as a traditional VAC therapy. She prepares the wound according to her hospital care protocol and applies the 3M Cavalon no-sting barrier film wipes provided inside the kit to protect her patient's peri-wound skin and allows it to dry completely. She applies the pre-cut foam in such a way as to fill and cover all the surfaces of the wound without pressing it down. For VAC Veriflow Cleanse Choice dressing, the honeycomb contact layer is placed directly in contact with the wound and then covered with one of the filling layers, depending on the depth of the wound. Then, Elise trims the VAC Advanced Drape to the appropriate size. She applies it, avoiding folds. She cuts a circular opening the size of a €2 or 10p coin in the field. She removes the backing layers of the VAC Veritrack pad and applies it directly over the opening. Elise prepares the VAC Alter Therapy unit by connecting the canister and fixing the VAC Verilink cassette, which she connects to the solution bag, which will be to be instilled into the wound bed. She connects the first tubing to the VAC Verilink cassette and the second to the canister previously attached on the VAC Alter Therapy unit. Elise adjusts the default setting on the VAC Alter Therapy unit according to the medical prescription. The unit is set by default to an installation cycle every 3.5 hours with a soak time of 10 minutes and a negative pressure of 125 mm of mercury. She can set the instill volume manually by adjusting the volumes of wound solutions according to the amount of foam used, or with the fill assist, which helps to determine the exact instill volume by allowing Elise to manually start and stop installation. When changing the dressing, Elise uses the dressing soak function to facilitate the removal of the foam. VAC Veriflow therapy is the evolution to VAC therapy. It facilitates and may help improve the effectiveness of negative pressure wound therapy through regular and automatic wound cleaning as compared to VAC therapy.
Hello, everyone. We've come to the end of the Rehab Breakaway session. I'd like to say a massive thank you to all our speakers and our sponsors, to Baxter, to Smith & Nephew, to 3M, to Aspen, to Baroque, to Molnike, and not forgetting Digital Access, who's made sure that this has gone off seamlessly and made the SABS Congress such a success. Can I ask you to please rejoin the main session and enjoy the rest of the Congress? Thank you.